So we're on record now. So welcome to week 9. It's an interesting week. It's all about musculoskeletal neuromuscular dysfunction. I know being in nursing school, I don't know how many friends and organizations I was in expected me and to understand how to take care of things like breaks and sprains and cuts. It's like, oh, you're in nursing school, you should know, right? Well, I think the musculoskeletal break strains are things that will give you some insight into that. When I was in nursing school at age 18 and 19. I was a member of a volunteer fire department, and I know that we were always active doing all crazy things. And I'm telling you, I had to take a first aid course so that I could keep up with all the questions because they expected you to know. So this is actually one of those weeks where information you can apply to friends and family and whoever you're working with. This week, all we have to do is that dosage calculation form. Now, what that form is, yes, all your answers are in your book. Yes, you can cut and paste it. But what I want you to do is try to review it, look at it, and understand how things are done. In pediatric medications, we know it's milligrams, micrograms per kilograms, units per kilogram. Um, but there's also different ways that we can figure it out. Your about by your body mass index, right? BMIs and those. And do you need to know how to really get those questions done? You're not going to use them. But it's nice to know that maybe in the future you're taking care of a child who maybe is not responding to medications, and maybe it's due to the way the weight's distributed, and maybe it could be a hint on how to dose those children more accurately. I've seen it once and it did help, so something for you to think about. So we're going to be doing this week first the PowerPoint, and then I've re-updated it a little bit, and I've also re-updated the Kahoots. Remember, next week is your exam. This week is going to be all of your reviews. So try to get to one as you can. I do mine on Wednesday at 5 o'clock. Again, I will post everything as soon as I get these reviews sent to me so that you will have them, all right? So let's go ahead and get to the PowerPoint. Now it's going to take me a little bit to score all of these projects, but I will get them done as soon as I can so that you can make sure that you have a chance to be able to. I'm trying to get this thing correct for me. Sorry. Maybe you have a chance that you might want to change it. Maybe I'm saying there's 20 points off because you didn't do this or that. I will give you that opportunity, send it back, but please try to get it in before Sunday. I'm trying to get all of these done before Wednesday at the latest. And remember, I do got about 50 of them. I've actually scored about 12 already over the weekend that we're in. And that's why I do it on the weekend, to try to keep up with it so that you get them as soon as you can. Now, I've always said,
Where are the PowerPoints for this week? I didn't see them in the announcement.
I didn't send you the announcement. Okay, I do.
Well, I have the week 9 announcement, but I didn't see them.
I didn't attach it. Okay, do you need it right now?
Well, I mean, no, I can get
Okay,
that.
I will, as I always do, I will send it with the recording, which I'll do right after class. I'm really quick with those.
Yeah.
What I think happened is I was renewing it, reviewing it, and updating it. And in the end, with everything I was doing, I had a moment called the senior moment. But thank you for letting me know that, Jennifer. Absolutely, I'll send it to you.
Thank
They're
you.
not mine, they're yours. So as I've always said, a picture tells a story. Now, we're going to be going over muscular, skeletal, and articular dysfunction. Well, we know children break everything, and we're going to go over that. Today we do have nice colored casts. Now, not necessarily like these pretty colors, but you go to an adult facility, you're going to get a white cast, guaranteed. Go to a children's hospital, and let me tell you, army, rainbow, yellow, pink, green, orange, blue, all different colors, and it actually helps distract the child from, I'm getting a cast and it's going to be manipulation of that bone. So it does really help, emotionally for these children, decreases their stress. Now, that picture to the right, that little baby has a hip problem. The hips aren't in the socket the way they should be. It's a Pavlik harness. And you can really look at that picture and say, oh, okay, it's holding abduction into that joint where it's going to, those tendons now are going to mold and it's going to pull that hip into the socket where it should be. And then the one on the bottom will go more. It's called Buck's traction. And it's basically skin traction, pulling the leg straight, and it's up over. And that little string, there's a weight on the bottom. Well, being immobilized, adult children, there's all many different reasons why. Sometimes in children, there is congenital defects. One of the things is osteogenesis imperfecta. It's a brittle bone disease. You really don't want to be picking them up and moving them because their bones are so fragile that just by picking them up with their chest wall cavity, you could crack a rib, and that's how sensitive it could be. And that's part of congenital or degenerative. We know injuries, infections, all of these things can make them not be able to move. About fractured pelvises, which happen, due to falls and accidents and whatnot. And we know that in any time you're immobilized, there is all of those chances for all the side effects, blood clots in your lungs and, atelectasis, et cetera, right? Now, there are some things that create you to be immobilized, and that was the last one. We're starting to get away from that. I'm going to give you a good example, which has changed over the years. You used to get a fractured femur, you were put in bed, they put a metal pin through your knee, and it pulled weights to hold that femur bone straight. And usually they were in the hospital for a month. We don't do that anymore. We'll put them in that Buck's traction because we don't want those little splinter edges getting into the muscles and nerves, creating pain and swelling until we do surgery. And today we put a metal rod down the center of the bone to give it that so they don't have to be immobilized for a month because that 1 month can create a lot of problems, can't it? So you're immobilized, you're not moving, you're not exercising, especially kids. You're going to see decreased muscle strength. You're going to see joints not be as flexible as they were. They're going to stiffen up, just like an adult. Oh, yes, children, the same thing. We know there can be problem with the skeletal system, with bone demineralization, difference in just the dietary needs are going to be changing. Okay, heart and lungs, blood clots, atelectasis, all of these things, dependent edema, and now we're talking possibility of sores, decubituses. Yes, children can get decubitus type of, whether on the hips, whether on the coccyx, the back of the heel sometimes, all of these things. Now, take a kid and put them immobilized. And, most of the time, these children are awake and alert and they're children. And they can't get up, can't get out of bed, they can't get for themselves. And you can imagine you're going to have one frustrated child and they're going to get a little aggressive because they're angry. They don't want to be there anymore. They're missing out, right? Their kids are doing this and that. Their brother and their sisters went roller skating, went to the movies, went to the pool. I can't do that. So it's a lot of things that go on. And of course, part of that separation anxiety, that regression, oh, it happens in a different way, but it happens when the child's immobilized. Then you put a kid in the hospital for a long period of time. Let's say that old time, Steinman pin, that metal rod for a fractured femur. Well, the family still has to go and visit that child, right? So it disrupts the whole family during the whole thing. So it really creates a burden. Now, one of the things I've seen in the pediatric hospital is those coping things. Now, many of the areas, for instance, cardiac, newborn ICU, neuro floors, they had monthly parental meetings where they get together, the parents, and they talk about what their frustrations are. They also talk about what they did that helped their child and resources. They share all these things, and they're a great thing to have. Now, injuries, children go out, run, fall, and bruises everywhere. Now, Christian just started, he's 7, just started to be able to ride his bike around the block because now he's looking for cars. He's not just riding out in the middle of the road, those driveways. It's not, he's watching those things. So we let him go. Well, bathing him that night, he had bruises up and down his knees, falling down. It's just part of being a kid, right? And it's what happens. In sports, he played soccer, he was bruised all over, kids were kicking him, the ball was hitting him. So these are just part of being a kid and what happens. Now, contusions, well, you can call it an ecchymotic area if you would like. But we're looking at a bruise as just a bruise. Well, a bruise, especially one larger, remember there's swelling, there's release of blood underneath the skin. It can compress on other blood vessels and nerves, and it could create a problem with neurovascular, right? Maybe blood is not going distally. In any contusion, crush injury, swelling, always check neurovascular signs distally. If you have that big bruising on the calf, on the thigh, check the dorsalis pedis, posterior tibial. It could impede on that circulation. Now, dislocations, the biggest one in dislocations I've seen is that nursemaid elbow. These are your 2 to 4-year-old kids. You swing them around with their arms, and all of a sudden their elbow clicks at a joint and it hangs to the side, and it's painful. It's because the tendons are just so soft and they're not firmed up yet. And they come into the ER, their arm is hanging there. The doc goes up, goes click, it's in, put them in a arm sling, they go home. That's the biggest location that I see. Now, I've seen them all over. I've seen ankles, I've seen hips, I've seen jaws. I mean, it can happen almost anywhere. One of the things with, especially your Downs child, now we know they're hyper flexible. Both legs can go behind their head, but remember they're pulling at that hip sockets. And remember, as I said, those tendons don't hold them in so tight so they could pop out. Now, whenever we have a dislocation, nursing care, well, they're going to be in pain. I mean, of course, give them something as simple as acetaminophen or ibuprofen, or more if they need something more like morphine. But remember that it's not where it should be. It's that hip joint somewhere else, and it could occlude blood supply. So always check neurovascular signs. Also, in the femur, the head of the femur, there's a big blood supply, and it could decrease it, causing necrosis of the hip. So the quickest we fix it, the better it is for the child. Now, have you ever had a sprain? I think these are worse than a break. A sprain, I remember playing volleyball, going up, spiking the ball, come down, and my whole ankle, and immediately could feel it swell, and the pain was horrible. It is the stretching of muscles and tendons and nerves, and it swells like crazy. I think sometimes a sprain is absolutely worse than a fracture. A fracture, it's there, okay, swelling occurs, but this is a ripping of more stuff in there. We're going to get into the treatment of that. Strain is when you do one muscle group over and over again. It could be that child rides a bike, right? And that just constant movement can cause it. Gymnastics, doing those different sort of stretching and movements could cause strains. I know I've had one just walking in the airport from Terminal 1 going up to 64 3 times back and forth because the plane wasn't where it should be, and I know the front of my legs have this big strain. So a strain can be most anything. So whenever you have this strain, the thing is to stop, to rest, to ice it as soon as you can. That causes vasoconstriction, decreases the amount of swelling, right? And elevate it. Again, it will decrease the amount of blood force, the flow going down to whether it's an ankle, an arm, wherever it is. And then, of course, an ACE bandage. Hold it tight so it can't swell. So it's rice. Rest it, ice it, compress it, and elevate it. And then we put in another one called an I, which is immobilize it, support it. We used to in sprains when I first started in nursing, just wrap it in an ACE bandage, and that was it. Depending on the level of sprain today, they might put some sort of splint on it or even a cast to keep it immobilized. So it's a difference in treatment. As I said, as nursing, you're always learning a new level of practice. They find what works better. Now, fractures is common in kids because they're up, out, and move, and they don't think, they don't filter what's going to hurt them, and it happens. Now, one of the most common is the arms, the radial and the ulna. I've actually seen bilateral wrist fractures of both bones, and this is when they first came out with that hoverboard. And the kids would poof right to the ground and it would fracture them. Most common. Now, in children, the infants, if we're seeing fractured bones, that's not normal. Number one, their bones are soft. They tend to be more pliable. It takes a lot to fracture a bone, and it does need to be looked at. I've actually seen a little twin come in who was 3 months old, who the mom said she's crying, and there was this little yellow purplish mark behind the ear. Well, as I picked that child up underneath the neck and the head and the buttocks to put on the scale, my thumb went and squished that area. And it was child abuse. What we did is we flagged the chart. I told the physician what I thought, and we did what we call a bodygram. I mean, an infant can fit on a whole x-ray film, right? You put them on top, you look at their arms, we looked at ribs, and we looked at legs. Well, not only did this child have a fractured skull, also had fractured ribs, a fractured humerus, and a fractured femur. So definitely child abuse. You know what made it worse? We called the other twin in, and the other twin had similar symptoms, worse. The 2-year-old brother came in, and he was actually all same thing, old fractured ribs, different stages of healing, and he was walking around on a fractured femur. We did find out who it was. We did keep those children safe. And the bottom line was keep the kids safe from this point on. It is not fun to be a part of it. And it's hard to be a nurse and see it and not scream and yell and want to beat somebody up. But remember, we're there for the kid, take care of the child, and then you've done a good job. So, type of fractures. Well, the most common is the simple one, where the skin isn't broken and there's a crack. Usually they're not displaced. And we're going to see it called simple. Now, open or compound is when you fracture an area. It could be a toe, a finger, an arm, a leg, anywhere. and the bone is fractured and it's sticking up through the skin. There's a laceration and the bone protrudes through. Once the bone protrudes through, it is opened into the air, and now we're worried about infections. The treatment is IV antibiotics for this child. That is the priority. We do not want osteomyelitis. And if we don't treat it aggressively, that's what can happen. And that could cause loss of limb, finger, toe, or whatever. Okay? Complicated is when you have a fracture that can hit an organ. I think rib fractures, the ones that could pierce a liver or pierce a spleen, that is a great explanation of that one. And comminuted is when it shatters into little pieces. Can you imagine the little tiny little sharp little pieces of bone, which are hard, that are all over in the muscles and nerves? Can you imagine how much that would hurt? And that's comminuted. Now, one of the areas that we really are concerned about with children and fractures is when it hits the growth plate. It's the end of the bone. And this is where the bone grows as you get taller. So, when we have a fracture of the growth plate, the treatment is surgery. We do an open reduction, internal fixation. They put screws and pins. They want to get that lined up perfectly. Or you're going to have a crooked arm, a crooked finger, a crooked leg, and it's going to be shorter than the other one. So, very important. Growth plate fractures is called the epiphyseal plate, and that's in the end of the bone. Now, look how quick bones heal. Infants quick. That's why if we have an infant with something like club feet that we want to realign it and reimagine the way that it's the shape of it and the positioning, we do it as quick as possible. Because look, 2 to 3 weeks neonatal, first 28 days of life. We do it immediately, we'll straighten those bones out. Remember, you can just on delivering vaginally these children, you can fracture something. It's not uncommon. It does happen. I mean, clavicles, I think, are number one, right? As they get older, it's about 4 weeks. And then later on in childhood, 6 to 8 weeks. And then adolescents and adults could be 12 weeks, 16 weeks or more, because we just do not heal the way young children do. Now, when you see a fracture, what do we do? What can we expect? Well, we're going to have an X-ray. We want to know what's going on, and we need a history. Now, I like to take those kids over to X-ray myself when I am, suspecting something. And I'll just very nonchalantly, non-threatening, find out, is it that they fell off the monkey bars or is it something else that caused that fracture? As long as those stories are matching and you don't see the kid afraid to answering, because you'll know when they're trying to say what mommy told them to say or what daddy told them to say. Um, when you start hearing those differences, then you would suspect. But it's just, again, a check. Not every child with a fracture has been abused. They're kids. But as a nurse, that is our job. So, one of the things in fracture is to make sure that we have it aligned, we immobilize it, and we preserve function, and we don't want a deformity in that leg. Too short, too crooked, whatever. Now, once we put a cast on, and I like to put some exaggerated type pictures just to show you what can happen underneath a cast. Now, if it's a one that's had need a cast, and this was an open fracture, a compound fracture, we're still going to have to be watching that area where it was open. Usually they put a window in the cast to check on it. Sometimes these children go and nobody looks at them. And yes, this is an extreme picture, the one to the right, but just to tell you that because the fracture and the swelling and compression of a cast, it can decrease blood flow that much that it can cause a minimum of a finger or a toe to become necrotic and they can lose it. So, very important that we look for pain. Is the pain getting better or is it increasing? The neurovascular signs, what's the color? Is it pale or is it pink? If we can feel a pulse, can we feel a pulse or not? How about numbness? And it's distal. So if I was fractured arm, I'm looking for the fingers, Can I move them? And can I feel when I'm touching them? That's the paresthesia. And then can I not move it? Then again, that's a lot of swelling. And of course, pressure. The pressure builds up. I mean, we've heard of compartmental syndrome. That means that cast is too tight. They need to get into the ER immediately. Call the orthopedic doctor, and usually they'll remove it, check it, and then replace a cast. It can happen, and it's stuff that we need to teach our parents and children to look out for. All those P's, very important. Now, putting cast on children, as I said, colors are great, right? Look at the little Cabbage Patch doll and the kid. They're both in the same thing. Maybe she likes watermelons. I don't know. Maybe lime green and pink are her favorite colors, but she's happy. And I'm sorry, that's hard to have a cast on that looks like that and be happy about it. But we made it as less, painful as possible, as in mentally torture. This is fun. I got great colors on. Now, how do you take care of casts at home? Well, we've done a discussion question. Talks about casting. It talks about nothing inside, no powders, no lotions. Don't stick anything down in there because it could cause scratching, it cause sores, and it could cause, a lot of infection. Another thing we don't think about is getting it wet. Now, I have seen little girls and boys get a cast put on their arm. They go home, put on their bathing suit, and jump in the pool immediately. I've seen one kid do it 2 times. I thought the mother was going to hurt that child because they have to go through the ER process again, right? If you leave it wet, it can create fungus and, it could create a big infection underneath. So we do give them these plastic bags for showering. And we do talk about, a bath, sticking their leg or their arm outside, and very, very important thing with it. One of the things that can help with itching is a cool hair dryer. Put it on high and it's just cool air blowing in there and it does help. Now, I mentioned in the very beginning about traction. There's skin traction, and which this is, and then there's that skeletal traction, which is like stuff that's like the stymon pin in the knee, sometimes the halos on the neck, where it's things that are screwed into the bones. Now, one of the things with traction is that is used a lot for a fractured femur. Well, let's look at a fractured femur. Most of the time, they're cracked in half. And now you've got these little sharp edges that are going into the muscles and hitting nerves and having muscle spasm and painful. Just a little movement, sometimes a deep breath, a cough can create incredible pain. So, what it does, it aligns the bone up and it pulls. So you have it in a place where the little pieces of bone aren't injuring and causing more swelling, more pain, in the area. And it's allowed there to be there until we can do the permanent fix. And that permanent fix would be that metal rod going through that femur bone. So these are two skeletal tractions. The one on the left would be for a fractured neck. I've used that on a little boy, actually a 16-year-old boy, who had already numbness in one leg and partial numbness in the other. And we put him in one of those within 6 hours of arriving to the ER. And the kid did well. He walked in a year later and gave me a hug. So it works. The other one could be surgeries on, the A1, the axle and atlas and the axis, those two C1, C2 vertebrae. Sometimes there's these things that can go on. They put it in that just to hold it and they can get up and move around. They don't have to be in bed like the other one. So the purpose is to hold it, of course, where it needs to be. That's always number one. It does relieve that tension on the muscles and it gets that bone approximated so healing can start healing, right? And it prevents that deformity. And the biggest thing, of course, is that reduction in pain or that reducing those muscle spasms. Now, there's all sorts of traction that can be used also. Now, this is Bryant's traction, the top right one. Hips are up elevated a little bit. They're at a 90-degree angle. And this is for dysplasia of the hip, DDH. We're going to go some more into that with the Pavlik harness. But this is one that we can use for a child up to 30 pounds. Okay? Buck's traction again, that is used for usually your fractured femurs because it pulls it straight, relieves all that pain. Russell traction is just the one that has just an extra piece. It's like Bucks, but there's another one that does right there at the area on that upper thigh where it holds it straight. And then, of course, you have your cervical and then the Gardner Wales tongs, which we seen in the other pictures. So that's the whole thing right there again. Bucks, fracture femurs, make sure those weights are hanging freely. We never, ever take it off. What happens if you took that weight off? The bones would slip out of place and they would go into muscles and create pain on it. And now you've gone, all the work you've done to hold it sitting there straight, maybe any bone healing, it's gone. And I've already talked about Bryant's and all those things that are there. So distraction. Open is called an external fixation device. And it's skeletal. And it sometimes could be used different ways. Could be a fracture that was so many pieces that just a cast or just one splint, are not going to work. And surgery right now is not going to work. Also, did you ever see a child with an arm or a leg shorter than the other one? We can break it, open it up, and get that extra inch or so that they need in order so that they're going to have legs the same length, so they're not going to be limping or need orthopedic shoes. With these devices, there's multiple little pins that go in there. And all we need to do as nurses, check neurovascular signs, of course, and that pin care, whatever the doctor says. Sometimes it's peroxide, sometimes soap and water, sometimes it's antibiotic ointment, sometimes it's not. Just keeping it clean. Whatever the doctor says is what you do. Now, children can be born without a finger, an arm, a leg, or a bone. I actually had a friend whose daughter was born and did not have a fibula in her lower leg. And she had to get a below the knee amputation to be able to be mobile as she grew older. And that girl didn't know she was different. In fact, the day she met my children, she was going up and down the stairs of my townhouse with her prosthesis, trying to beat my kids over their heads. So she didn't know, she didn't care, and she was very alert and active. That's one thing that can happen. Remember, sometimes it could be due to an infection, an osteomyelitis, could be some sort of accident that's created crush injuries that they had to remove a leg, an arm, or whatever. The one thing that we need to remember is that that phantom pain and all those things that we know with adults, kids go through too. Our goal when we have to remove any part of the body, especially arms or leg, is to keep an area where a prosthesis can be placed there so they can continue being mobile. That's the big thing. Keep them mobile. Also, again, making sure they're pain-free or as little as possible. Now, children love, love, love competition, right? They like to go out there and, hit kids, knock them over, and it's just part of, being a kid. We know that children tend to push themselves as far as they can because, again, they want to win. They don't like losing. So there are a lot of demands, physical demands with it. One of the things we have to remember is to be wearing the proper safety equipment, whether it be helmets, knee pads, elbow pads, wrist restraints, shoes, making sure they have what they need and not to let them go to the point where they're doing those overload injuries, like they're doing it too much. They do need having rest breaks. I mean, kids are still growing, and they should be given that opportunity for those restings. Overuse syndromes, the Olympics comes around and I always think about this and these young girls and ice skating and gymnastics and all of those outdoor track and field. I mean, how much have they pushed their bodies, right? They are expected to train longer and harder. And, in ice skating, they're starting at young ages and gymnastics. I know my little girl, she never went on in gymnastics, but it's what parents do. They put them in something. Well, she was in gymnastics and she was there by the age of 6 and 7. And, they did really stretch and overwork, the muscles, et cetera, et cetera. Remember that there is always concerns, about the shoes they wear, the equipment they wear. Does it fit? Is it rubbing? Is it causing sores? Also, those fractures and strains. It happens. It's normal because of overuse. Now, I mentioned DDH a couple times. It's called developmental dysplasia of the hip or congenital hip dysplasia. What's one of the things the pediatrician does? One of the first visits to the doctor's office. They're going to be checking their hips, right? They put their knees up and down and back, and they're listening for clicks and they're making sure that it's in the right place. Usually, your femur, the head, goes right into the hip and it sits there nice. With developmental dysplasia of the hip, it's anywhere up to the point up top. So our goal is to get it back in there as much as possible. Girls are more. Now, what would you see? You get a new infant in and the doctor's going to do a visit, but we're in there doing our vital signs first. And I always like to catch this stuff to tell the doctor, right? So we're going to see that their hips, one of the limbs, the legs, the one with the hip problem, because that is up here, not in here, it's going to be a shorter leg, right? If you look at their buttocks, one's going to be up, one's going to be down. You're going to be hearing those clickings and sounds in them. So this is what would be seen. So what do we do? Well, as I said, when they are neonates, first 28 days of life, and we'll be checking it, usually by 2 weeks, we figure this out, if not at birth, in, the hospital before you go home. Well, we put them in a Pavlik harness, and it causes abduction. And they wear this 23 hours a day. Now, do you notice the difference between the one I showed you at the beginning of the PowerPoint and this one? The one in the beginning did not have a cotton t-shirt underneath. This one does. And why would you want it? Well, they're moving, they're rubbing, right? And it could cause some sort of skin breakdown on it. These children, we need to massage those areas. Those, when we take it off, usually it's for their bath time. And then we put it right back on So massage the area, examine, looking for breakdowns on these children. We want to make sure that, that's not going to be a problem. Now, usually that will take care of it, but sometimes it's so stiff it doesn't. And then that's when we put them in that spica cast. That was that pink and purple type of cast that we saw, but in a smaller child. Okay. Usually it's a lot smaller. I remember growing up, my girlfriend had a sister was in that cast. I had no clue what it was. And then I became a nurse and I said, oh, that's what it was. She had hip dysplasia. And I remember holding her by the stick and carrying her around with her sister, getting her around, her house. And that's up to like 2 years old. Now, if it does not fix by then, those tendons and those bones are so stiff, it's going to need some sort of surgery to release it to be able to get those hips where they need to be. Now, I mentioned club feet, right? Club feet is you don't have to know all the names. It could be inwards, outwards, up, down. It could be all different positions. That's all you need to know. Sometimes the toes are pointing down. But remember, their bones are nice and soft at birth, right? So what do? Well, as soon as possible, we're going to be doing, we usually call it the Ponseti method. And that's putting casts on these children, all right? So let me go back. Well, what they do with this is every week they come in, because remember how quickly they're soft and they will correct that quick, and we'll change casts every week. It could be for the first 8 weeks of life. You do not wait, for a month to get these kids in. Every week they need to come in and they'll be doing this serial casting. As they get older, we need to make sure that they follow up with a podiatrist, making sure that their feet are the way they should. They should have better shoes than just going and getting a cheap pair of shoes. They're going to need that good pair of shoes. Now, I mentioned osteogenesis imperfecta. This is brittle bone disease. It's metabolic. There's no treatment for it, and it is inherited. The treatment is just supportive. There's really nothing much we can do. I mean, our goal is to try to maintain body function. At least they can be in a wheelchair. Now, I've had these kids in a wheelchair and going to the cafeteria, you'd hear these kids going beep, 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 and you look behind you, and there's this little kid in a wheelchair, boom, going to the cafeteria before you. They are awake, alert. They're normal kids, but their muscles and bones don't really work. So these children are not going to have any aggressive anything because just with slight movements, they can break. So that's that one. Late calf birth. This is what we call an aseptic necrosis of the femoral head of the femur, which means the femoral head is there. Something's happening, which is not an infection, which is decreasing blood flow to the head of the femur. One of the things with this is it's not antibiotics, it's not viral, we don't know, so we treat it just by rest. We might, to relieve pressure on that femoral head, put them in Buck's traction. So sometimes it's bilateral, but usually it's one of the femoral heads. So it happens. What and how would you know it? Well, all of a sudden, this kid starts limping, and especially when he's been sitting or just in the morning, where he gets up and it's like, oh, it hurts. And they do an x-ray and they see the foggy edges of the femoral head, and they know by looking at that it's probably late calf birth. And you can see that little fuzzy area type thing. NSAIDs is what we do. Sometimes surgery, but usually not. Is that home traction and rest for these kids. Now I'm going to go into 3 different problems with curvature of the spine. Now, kyphosis is another word for humpback, right? It's the upper thoracic spine, and it's like you're just leaning over, and it can cause later on in life, arthritis. Okay, and there definitely is an osteodystrophy, vitamin D, calcium problems could be with it, but it is that humpback. Lordosis is when the lumbar spine curvatures in and they lean back with it. There's one diagnosis that will have this as one of their symptoms with it. And the one that mostly is looked at, tested upon, that we will see is something called scoliosis. It's an S-shaped curvature of the spine. Now, if you look at the picture to the right, do you see how that spine pushes over to the right side? That one shoulder's up and one is down. The problem is how many degrees of displacement is there? If it's really displaced, it's pushing that lung and squishing it. So your lung capacity decreases on this one. Sometimes we don't see this in kids until that pre-adolescent growth spurt where they grow really quick, at that pre-adolescent stage. And then all of a sudden we will see them with this curve. Again, what do? We'll do an x-ray, we'll look at it. You can see how that is pushed over into the right lung, right? The left side is area to move, but the other one doesn't. One of the things that, remember, these are your adolescents' body image. They don't like that their clothes don't fit right, they're crooked, so we need to do something. Well, if it is a curve less than 40%, we're going to do a twofold thing for these children. We're going to put a brace on them. And sometimes the braces are just clear white plastic type. Sometimes that you can get colors on them. It all depends on where you're getting them from. And again, 23 hours a day, that must stay on that child. And if you see again, there is a cotton shirt underneath. Again, no lotions, no powder underneath there. When they take it off to take their shower once a day at that 1 hour that they got, they're to inspect, making sure there's no areas of breakdown. Now, if this curve is greater than 40%, usually when they start maybe up to 50%, they're going to have to do surgery. And they do something called Harrington rods or Lukey rods, or they also call it a spinal fusion. And they try to straighten out the spinal cord as much as they can. They put a rod in the back and they attach the spinal cord and try to straighten it. Now, is it going to be perfect? No, but it will be a lot better than what it was. So put a brace on them, and they're given exercises to strengthen their abdominal and back muscles so that we can keep that straight. Now, osteomyelitis can happen anywhere, any bone. And kids, actually, I see it a lot on their big toe or on a finger, where they got into something, it got reddened, and they just nothing, wash your hands, and all of a sudden they start with a fever, and now the finger or the toe is now red and swollen, and it could get to the point what this one looks here. I took that picture because the red and the swelling was quite significant on it. Now, do a CBC. What do you see? Well, it's an infection. It's usually staph infection. So marked leukocytosis, white counts could be 20, 30, 40,000. What we like to do is take a culture, if there's an area that we can get, or if there's a swelling, try to aspirate it because we want to know what bacteria. We can always say probably it's staph, but just to be sure. And x-rays don't always show it, but bone scans do show hot spots. It's a good thing to use. So, if we have osteomyelitis, usually these children will get some sort of peripherally inserted central catheter, a PICC line to go home with, and they'll be given antibiotics IV because it's a bone with a staph infection. It really needs treated. Well, what do we know about antibiotics that treat staph? Vancomycin, amikacin, gentamicin, all the SINs, the aminoglycosides. These are antibiotics that can hurt your hearing and it can also hurt your kidneys. So they need to have very close monitoring of their drug levels. This is the peak and the trough that you learned about in pharmacology, making sure they're right. Also, we're talking about bones, nutrition, right? They need calcium, they need vitamin D, these and protein for healing, right? These are things that they do need. These children, if it's like a leg, we want to bed rest and immobilize it. We don't want to tax that bone at all. And again, these kids now are on bed rest with an IV. They're in pain. So pain medicine is wherever that level of pain is. They need distraction, especially older kids, those adolescents need their friends. I mean, we're so lucky of FaceTime today. 20 years, that wasn't there. What did you do? You had a phone, but it wasn't the same thing, was it? So there's so many things that we can do to help these children. Now, this is a cancer and it's in with the bones. And why? Because it comes from the bone marrow and it is the fibia, the femur, the tibia, the ulnar. It can also be in the cheeks and the scapula. And it is malignant, and they try to remove what they can of it. Ewing sarcoma. So whenever there is a bone involved, an area, you don't want to have to remove more than you have to, right? You want it shrunk up. So radiation, then chemo, and then we'll take out that piece that we can. And if something that we can save, we're going to try to save in it, okay? And hopefully we caught it before metastasis. Now, rhabdomyosarcoma is muscles, right? This is those things like in the nose, on the gums, in the ears, type thing. It also could be in the peritoneum and retroperitoneal area, and it just gets bigger. And again, this again is malignant. So radiation, chemo, and these children usually with this are on a long-term chemotherapy. Now, JIA used to be rheumatoid arthritis, right? But they call it juvenile idiopathic arthritis now. And we know it's when the body starts attacking its joints. We see these in children, 1 to 3 years old, we'll start to see it. What do we see? Well, this is a kid who's just starting in the morning to limp, is stiff in the morning, or starts waddling back and forth because of the pain. We might see the point where we see that swelling and disfigurement, but that's when it's been there for a while. And uveitis, as you can see, it's when the eye gets all reddened and it can cause blindness. So they do need to see an eye doctor. Now, finding out if it's rheumatoid or idiopathic arthritis is difficult. In my case, it took 10 years for them to figure it out. And that was me being to the doctor, changing rheumatologists, doing everything I could. I was positive results, negative results, positive results. And finally there was one test they did and I was off the charts way high. Should be less than 50. I was greater than 250. And that's when they finally said, "Oh, yes, you are." I'm like, "I've been telling you this for 5 years. Nobody's listening." What do you see? In JIA, you're going to see the inflammatory factors elevated because your joints are upset, they're irritated because your body's attacking them. So you're going to see sometimes elevated white counts, leukocytosis. You're also going to see elevated the SED rates. There's also something called a CRP, a C reactive protein. That's elevated. Again, all inflammatory factors will be elevated. And you might see the ANA or rheumatoid factor positive. And as I said, they were negative and positive for me. So I was very hard to diagnose. How do we treat it? Well, there is no cure, something you got to live with. So the biggest thing is with deformities to try to decrease those deformities, preserve the function, and then relieve the symptoms. And the symptoms are pain and stiffness. So NSAIDs for pain is what helps the best because it's anti-inflammatory. Um, the big things they always use start with methotrexate, whether pills or with injections. Your corticosteroids, your steroids are a band-aid. It helps with the inflammation, but doesn't help with what caused it. But corticosteroids are used when there's flaring, when you're really in pain. And it does decrease the pain, but corticosteroids have a lot of other problems, related with it. Elevated blood sugars, decreased healing, weight gain, and then Cushing type syndromes, right? All of those things, which is what happened to me. So I know for sure. Humira is one of those things that we give as a biologic, and there's so many different biologics. What I found out through me and what I went through, just like there's antibiotics to treat certain sort of bacteria, there are different biologics to treat different types of rheumatoid arthritis. I think I've been on 6 different types already. So I'm okay with this one, though my voice isn't good, so we'll figure out. I've been on this one for a little over a year. So hopefully it will work eventually. That's the goal. These kids, big thing, stretch, exercise, motion. I have found out swimming in a pool is the best because you're floating, you can stretch, you can move, and you don't realize you're exercising, right? Again, using hot or cold. Now, do not put heat on me. Give me ice. Give me a bucket of ice. I'll stick my feet in them. Heat makes me feel worse. Again, personal choice, whatever works for them. So getting them moving, exercising, of course, good nutritional health, any hot or cold. And then in flares, it would be the steroids. Now, lupus is the body attacking any organ. Could be skin. That's why you get that butterfly or type of rashes. It could be, your heart, your lungs, your kidneys, anything. One of the triggers is hormone imbalance, and that's why we start to see it girls ages 10 to 19. That's that, menstrual time, right? Hormones, puberty is going on. We see more African American, Asian, Hispanic, and we know if one person in the family has it, possibility another person, that's when it increases it. We know that sometimes it's drugs that can trigger it. Could stress triggers anything. That's always a good answer. But sunlight. So being careful with sun, wearing sunscreens, minimizing the amount of when you go out in the sun, all of those things are important. As I said, it's that rash, butterfly rash, and it could be looking like anything. I mean, we saw this girl, little pink rash, but this one looks different. They're still a butterfly rash. Usually, the older girls, when do we figure out what's going on? Well, usually they start with that generalized weakness and then, nausea, vomiting, diarrhea. They think it's a GI problem. But then they're starting with lymphedemopathy, the lymph nodes. They're starting to see something. If it gets to the point protein is in the urine, okay, that's to be looked at. Pleurisy again, that's the heart, something's going on. And then it can get to the point of a young child being very forgetful, and seizures, of course, will always be one that we'll search at for further. So again, these children needs to be up and out and moving and be very careful, with the sunlight, and taking the meds as they should. A lot of treatment on lupus is a small dose of steroids a day. That's one of the things. So Kirsten is a 10-year-old sustained a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider that what? What's an epiphyseal plate?
In the growth
Is
plate.
the growth plate?
Absolutely, it is the growth plate. We know that that child's going to be prepared to go to surgery, an open reduction internal fixation, because we want to keep it straight. We don't want a shorter arm or a crooked arm if it's the arm. All right, neuromuscular or muscular dysfunction. Well, when you think of muscular dysfunction, a lot of time your mind goes directly to cerebral palsy. Cerebral palsy is a permanent disorder and it's all about movements and postures. The muscles and the nerves just don't work the way that they should. It's due to many different reasons. It could be from birth. It could be due to something metabolic, something in the brain. And we know with cerebral palsy, many of those children also have epilepsy. So these are the things that could be done from. I've seen cerebral palsy because of a hypoxic episode or an anoxic episode at birth where they couldn't get the child out. And they had to, run back and do a quick C-section. And there was a moment that there was a hypoxic or anoxic moment. It could be due to a hemorrhage in the brain. And as little babies, we know their brains are fragile. And a lot of times that's what it could be. So, diagnostic evaluation, well, a lot of times is just what we do every day. It's looking at the growth and development, that assessment, seeing fine motor skills, gross motor skills. Are they doing what they should? Or are you seeing things like hypertonicity, that spasm, that tightness that you see, poor posture, difficulty maintaining balance as they get older? And these things are those little clues that will say, okay, this is cerebral palsy. We will be doing neuroimaging, looking at the brain, see what's happening, and of course, any metabolic or genetic to see, making that final distinction is cerebral palsy. So what do you see as the kid gets older is when you see these the most. And that's delayed gross motor development. This kid may not be able to walk, and the kid's 2 years old. They have to, with these children, the earlier we institute interventions like on physical therapy, occupational therapy, and then of course speech therapy too, the child will do better. And because the younger it is, the more we can get from them. So it's important early interventions. They're going to have abnormal motor performance. They're not going to be able to really take a spoon and put it in the food, and the arm is moving in a way that they can't catch up with it. These kids, Usually, they're not walking a lot. Many of them are in a wheelchair, especially the more spastic cerebral palsy. They make sure that we put those seat belts on, hold them into their chair, making sure they're not going to slip and fall out. Their reflexes will be already, abnormal. Now, there's all different levels of cerebral palsy. I mean, when I think of cerebral palsy, I'm thinking about this one little boy that was in my clinical site, little Jonathan, 7 years old, spastic, nonverbal. And me and that child had such a great bond. He would see me smile from ear to ear, and his arms would go up and he'd get really spastic. He was in a wheelchair. He could move around. He had the ability to talk because he had one of those electronic pads where he could tell you what he wanted. So there was a method of communication with him. So he was able to have locomotion and he was able to communicate. He really couldn't do a lot of self-help stuff, but if you have him here turn over to your side, he would always try, especially because he was 7, he still was incontinent. He wasn't potty trained. So he would try to help in many things. But giving him that opportunity to be able to communicate, move around, was a big thing for him, and you could see it. These children need to be integrated into normal activities. Sitting there and let's say you're watching in a group, let's say it's that daycare where we have these children that they are participating, clapping their hands when they should clap or go hoorah, whatever it is. Having them be a part of that because just because they can't communicate, just because they can't control their muscles doesn't mean that they're not inside there. So giving them that opportunity is all that they need, and you're going to see them do more than you ever expected. Because of these spasms and these muscular contractions, they need to be in those ankle foot braces so that they don't go to foot drops because that muscles will spasm down like that. Sometimes they need surgery because and release tendons because they are spastic and they've gotten to that point. They will be getting something for spasms. Botox is used a lot in muscles that are super tight. Because these children are many of them prone to epilepsy, they're going to be on anti-seizure medications. What's the big thing about phenytoin and Dilantin? It causes gingival hyperplasia, right? So good dental care, very, very important. And Jonathan didn't eat by mouth either. He had a G tube, a gastrostomy tube, and he couldn't talk. So I'm talking, he was in severe spastic cerebral palsy, but me and him had such a great relationship. Um, and he could communicate, and I love that. Again, physical occupational therapy and then speech therapy, absolutely, that he could communicate. He was, many years ago when I was in high school, I used to go to this place where they had all these children and adults with cerebral palsy, and I used to help out. I volunteered. And I remember we didn't do these teaching. I didn't know that they could communicate. You would help them feed, get them up out of bed, put them to bed, put them in front of a, TV with their wheelchairs. And we didn't do much. This child at age 7, now mentally he wasn't up to a 7-year-old, but he knew his colors, he knew his shapes, he knew how to communicate. So much more than we ever thought years ago. So prognosis depends on the severity of them, okay? Um, 85% can achieve ambulation. Now, Jonathan, no, but many of the other children at this daycare could. And they would have these walkers and they'd have their braces on and they'd be working from short distances to longers. Yes, cognitive impairments, they are, but just because he can't talk doesn't mean that he's not there. which I learned very quickly with them. Most of these children are a little bit, smaller, their growth. And many times it's those comorbid conditions. It could be, deep breathing and coughing and pneumonias, or maybe they have another thing, diabetes, usually, or infections. That's usually what is, what ends up ending their lives with these children as nurses. These kids are only with us in the hospital or at these prescribed daycares for a certain amount of hours a day. The rest they're home, making sure that they have the proper equipment, making sure they know how to give medications, how to give those gastrostomy tube feeds, how to be safe. Safety is always number one. Little Jonathan was spastic, and if you didn't watch him, he could roll off of a bed and could fall and could hurt himself. Give him something to do, recreation. I mean, this daycare had what we call a swimming day, where they put all the kids in a bathing suit. They had little pools outside, and they sat Jonathan in water, and they had water squirting. And I'm telling you, I've never seen a kid have so much fun in his life. And I would squirt him in his face, and I would splash myself and splash him. And it was probably one of the best days that I spent with that little guy. And again, families need support. Now, neural tube deficits. This is your spina bifida that we usually think of. One of the things that we call that big purplish blob on the back, and it could be either small or large or even larger than that, is called a myelomeningocele. Let me describe it so we'll understand more as we go further. If you can imagine, that's the meninges and the spinal column, which from the lower extremities has been pulled up and ripped and put on the outside of the body. So the lower extremities are going to have nerve damage, right? Sensory problems, and most likely are going to have minimal or no movement in the lower extremities because that nerves and meninges are pulled up, and the nerves that supply the lower extremities are right there. What's the other thing that we might be concerned about? Well, those are nerves for your bladder and for your bowels. So I'll be monitoring that also. So, neural tube deficits. Do you remember hearing that with folic acid in pharmacology? If you don't take your folic acid before you get pregnant, you could have a neural tube deficit. And the students say, well, what's that mean? Well, it means that the tube, that spinal column, could be born on the outside. It could be due to a couple different things, but usually it's mom, maternal obesity, diabetes, or low B12 that can cause it. So when this child is born, one of the things that we're going to have at bedside is a sterile dressing and sterile normal saline. And we need to cover it to keep it moist and to keep it sterile until we can get it put back inside of this body. Okay? These are children because they're going to probably be having urinary catheterizations every 4 hours because they're usually that nerve doesn't work. Also, multiple procedures. These children immediately latex allergy. Years ago, all we had was latex gloves, but today, no. And thank God, because I have a latex allergy from the amount of latex I used in the early 80s in the newborn intensive care unit. And I had some itchy on my hands, and I ended up with this bad allergy to it. So we actually don't use it. Rarely do you see it, but there are things like medications and appliances that could have latex. We got to be careful. Remember, we have to worry about bowel control and we have to be really considerate about urinary function. Are they urinating? Because they're going to have decreased feeling in their lower extremities. And with that decreased feeling, they don't know when their bladder gets full. So we have to be careful. Also, orthopedic because they don't have that movement in the legs like they should. They're going to need physical therapy to keep it moving. Now, These children, in their brains, they're perfectly normal. Let me tell you about Manuel Louis. I went to work one night and there was different rooms. So I was in a room and the other nurses had gone off to get equipment for the night or whatever. I was in the room alone and this mother was looking at a boy that looked just like this, Manuel Louis, and she was crying. And I wasn't my kid, but I'm not going to let a mother sit there and cry. So I went up and I said, "Mom, what's the matter?" And she goes, "Well, the doctors don't know if he's going to make it. And I'm so worried. And I just love him so much." And I went, "Mom," I said, "your kid is beautiful." I says, "He might have some issues with movement of his lower leg, but you look like that mother who's going to take the bestest care of him." And I did something unusual. Had the mother sit down. I loosely put this child with a blanket to keep him warm, and I put this child in her lap. And she just sat there and rocked and cried. Now, 14 years later, she found me down. I was now working in the emergency room, and I saw her pointing at me from across the room. And the ER clerk came and said, "That woman wants to see you." And I walked out and I saw Manuel in a wheelchair. I knew who it was. I don't know how. The kid was 14. And I saw the mom and she said, "You are Betty Boop. And I want to thank you for what you did that first day with my son. He is the most amazing child. Your words of encouragement helped me in the beginning, which was so difficult." He just went to his eighth grade dance. He had a date. He's in regular school and he's the most amazing kid. And the kid said, "Can I hug you?" So I bent over. I hugged him. I hugged mom. This woman had a keychain with a plastic thing about this big, and in it was a picture of me holding Manuel Louis as a newborn. So you think that you don't make a difference. You make a huge difference. And that kid, he may not have all movement in his lower extremities, but the kid is perfect in mommy's eyes. We know it's taken that that folic acid does help. We don't always know we're getting pregnant though. Now we're going to go into some of those things that can cause muscle wasting. Okay. One of them is Werding-Hoffmann. We call it the floppy infant syndrome. It is not, it is a recessive trait, so it can be repeated in another child. The thing is with these children is within the first 2 months, this kid doesn't lift their head, doesn't turn over. They're like in this frog position all the time. And they usually die before they're 2 years old. This is, one of those things. Werding-Hoffmann. It's floppy infant. And the kids, by 2 are usually not with us anymore. Now, the most tested of all these type of neuromuscular things is Duchenne muscular dystrophy. It is a progressive wasting of the muscles again. Yes, it's the most severe and most common. These children get this disease from mom. It's the X link that gives them that mutation. It is males ages 3 to 7 that usually get it. Now, when these kids they're walking, they've got hypertrophic or big calves and big upper arm muscles. You'll see that in them, okay? And one of the things is all of a sudden this kid's going to start getting more and more weak and start falling. And these children will be a little bit cognitively delayed. This is the one that they are. And these children end up in wheelchairs. The goal is to keep them from being too heavy because they tend to be overweight, and they also tend to be that one that needs that physical therapy, the occupational therapy. This is the child with that lordosis in the low back, okay? So big arms and thighs, calves, and that lordosis, that waddling gait and falling, and then something called Gower sign, something I do to get off the floor all the time. I crawl up my legs with my hands to get up. When it's like I'm stiff, I'm going to crawl up my own legs. Well, they do that normally. Now, there is no cure with this at all. Usually, when they decide that is Duchenne muscular dystrophy, and they see progressive muscle wasting, they're going to do an electromyogram for this, and it tests nerve impulses and how quickly muscles respond to it. And I've had one for a neck injury many years ago. And when you're done, it's like you have done the Olympics. You are really uncomfortable. Something we need to remind our children about with this thing. That it'd be uncomfortable, but it's, it will go away, just like exercising too much for one day. We try to keep them as much function as they can, range of motions, bracing, exercising, and remember, it comes from mom, so genetic counseling. Now, Guillain-Barré. Guillain-Barré starts with the feet and it works up. So we call that ascending, from the feet working up, and it affects nerves. Usually we see this in children. Many times it's in adults, but children can get it, where all of a sudden again, they're falling, their legs don't work good. Then they're already potty trained and they start being incontinent because now the nerves in the bladder, they're getting constipated because the nerves in their bowels aren't working as well. And then it attacks the phrenic nerve and they stop breathing completely. These children are awake, alert, but they can't breathe. So, nursing care, I'm going to have an O2 sat monitor on these children if they're coming in for this, right? I want to make sure that they are breathing. So it starts out with that muscle tenderness, paresthesia. It starts out with a paralysis from the lower extremities, and then it comes up, and then it's going to hit the urine, and it's going to hit the bowels, and then it hits the phrenic nerve. Our biggest concern with this one is monitoring their respiratory effort, okay? Treatment. IVIG, maybe steroids will help with it. And of course, plasmapheresis is just removing stuff from the body, the blood that is maybe could be affecting it. They're not really sure. And then respiratory. I actually had a nursing supervisor I worked with who ended up with Guillain-Barré. She was like 28, which is pretty young. And she ended up with Guillain-Barré and ended up admitted to our hospital with Guillain-Barré on a ventilator. And I watched the progression of it, where she was awake and alert, but she couldn't breathe. Can you imagine that feeling of total helplessness? It's mind-boggling, to tell you the truth. Now, they're not breathing, the ventilator's breathing all for them, and then all of a sudden, you start seeing the patient breathing over the ventilator. And then that numbness starts going down, and it starts going down. Usually full recovery of this with physical therapy when they're done. So ascending starts from the feet, works up. They stop breathing, then we give IVIG, steroids, and just total body care, turning, positioning, sometimes those beds that are moving, all of these things, monitoring urine, monitoring bowels, and then all of a sudden they breathe and they come back. Now, tetanus. We think tetanus is no big deal, but Tetanus shot should be given one every 10 years. When I first started nursing, I think it was every 3 years or 2 years. Then it started to 5 years. Well, now it's every 10 years. So tetanus is given because tetanus is all the upper neck, jaw, stiffness, swelling, can include the airway and stop the breathing. So it is a dangerous thing where you will start seeing that difficulty swallowing, laryngospasm, and then they're not breathing, and then everything is rigid and tight. Okay. So they give tetanus a vaccine, tetanus toxoid. They watch these children. They're usually paralyzed because their muscles are so tense. It hurts so bad, right? A muscle relaxant, paralyzed. They're sedated. They're intubated. And if they come back, it's usually about 4 days. They say they come back, they'll make it. But if not, they're not. With just tetanus, which is a dirty wound that had tetanus in it from the soil. That dirty nail, we used to say it's the rusty nail you stepped on. So tetanus toxoid that we do give, a lot of times we will see a kid come in with these things. We'll even inject around the wound this tetanus toxoid or antitoxin, and that helps. I've seen it used also for raccoon bites. Believe it or not, in Florida, a raccoon bite, and we did use it around there. It is from anything with dirt, saliva, etc., etc. And again, hopefully that they're immunized and we're just giving them a booster and they can come back from it. So they're paralyzed, sedated, their muscles are just tight. What are we going to do? Well, wherever that wound is, we're going to clean it. Soap and water is it, maybe an antibiotic ointment, but keeping it, watching it. And of course, intake, output, and watching electrolytes are always there. Now, botulism. Have any of you had a grandmother or an aunt who says your baby's constipated, give a little bit of honey, it will help them move their bowels? There are some cultures that believe that. Well, do not do it. Some books say 1 year, some books say 2 years, no honey. And that's also that corn syrup, that Karo corn syrup, light or dark, should not be given to them. We don't know how long it's been there, how was it prepared, was it, sterilized, etc., etc. So do not give it. Again, this is those things with speech, vomiting, and all respiratory. Life-threatening respiratory paralysis, okay? You ingest the honey, and within 12 hours to 36, you're going to start seeing these things. And usually in the infants, it's the vomiting and then difficulty breathing. Again, what do? IVIG, respiratory support, right? And always in any condition with a kid, it's always nutrition. Now, spinal cord injuries could be motor vehicle, sports. How about at birth when you're pulling that head out of that birth canal? Yes, you can have spinal cord injuries. How about that hyperflexion, hyperextension, getting hit from the back, head forward and back? That can cause things like that also. Now, I was mentioning earlier about a spinal cord injury. I was another story, guys. 16-year-old. I was the primary trauma nurse. So whatever comes in, I'm in charge of that patient. And this kid at age 16 was out playing baseball. He slid into third base and his head hit the defender's knee, and the stands even heard a crack. There was people there that knew what they were doing, so quickly they got the neck immobilized. Rescue came and trauma alert helicopter brought him to us. The right leg was completely numb and the left he could barely move any toes. So this is a big thing. My priority, that spine, keeping it immobilized, and you're in charge of that spine. I actually did an MRI on a child with a spinal injury from the ER. It's the only one I've ever done. And we have to move them off a stretcher onto the MRI table. So it was a big, big, big deal. That child went up to the ICU. He had a C5, C6 angulated fracture. I mean, your spine should be like this. His was angled like a little triangle, and the numbness was there. We put those tongs on his head because it was a Sunday, put him on a cooling blanket with all sorts of medication so that he could deal with that. So, some pain medicine and also some midazolam, which is your Versed, nice and calm. And that cooling blanket decreased the swelling. He went to surgery. I went to visit him 2 weeks later. That child had a little bit of numbness left on his right toe, but that kid was going off to rehab. And as I said, 1 year later, this kid came back and found me and gave me a big hug and told me thank you. Absolutely no residual weakness on this child. So nurses are important again, right? So what is that floppy infant syndrome? Which one is it? Oh, it's wording. Don't worry. I'm not going to put you through that pain. Anyway, lots of stories, a lot of information, and I think they do explain these diagnoses a lot. Who would like to win a cahoots today? I know Solis wants to. I know Kayla wants to. Oh, Jennifer, I see the smile. Aisha, is it your turn? Okay, Lori, you're going to do it. I know you are. You and Kelly, you're very competitive. Here we go. There's like 45 of them, and I think it'll lead us right to where we can be done with class tonight. Week 9, 2 weeks, HESI. A multi. What is the priority for a nurse to assess following a cast application? This is part of the PPPPs, right? We want to make sure pulses, pain, paresthesia, paralysis, all of those stuff. Remember PPP, there's 6 of them. Another multi. Patient teaching for a child with a fractured bone that has had a new cast applied. So it is a cool hair dryer that can help with the itching. No powder, no lotion. Don't put anything inside of it. And children, nothing wet. Even taking baths and showers, you have to be careful with. What should the nurse monitor after a soft tissue injury? I mean, soft tissue, you're talking ecchymosis, right? You're talking swelling, inflammation. What's your biggest concern? And it's usually distally that we talk about it. It's all about neurovascular checks. Remember, if we don't check it, it could be swelling up, especially crush injuries. We can't see it from the outside, but maybe a blood vessel has been occluded and now you're not getting blood flow. It could cause depth of tissue. You could lose a toe or a leg. A fracture that penetrates the skin is called. Is called a compound or open fracture. Okay, simple, no open. Green stick is when it's crunched. So it is compound or open. Another multi. Bryant's traction. Which one is that used for? I think I need to check my spelling a little bit. It's everything. Children less than 30 pounds is for that DDH to keep those hips, put it back where they need to be. Their hips are elevated and they're at a right angle. And always, whenever you're in traction, check for skin breakdown and maybe massaging it underneath if it needs it. What is the priority nursing care of a child with a compound fracture? Compound fracture, open fracture, the bone sticking out. It's all about infection. IV antibiotics. Now, are you going to be given pain medicine, neuro checks? Absolutely. But priority, prevent infection. You don't want osteomyelitis. What is a priority nursing care for a child who fell off a second floor balcony? Now, I've actually had two young kids go out on the balcony, second floor, get up on a chair, and went over the edge. The only thing when you're talking about a fall, a possible fracture in the neck spine is immobilization. That's your biggest thing because you're going to have paralysis without it. Now, are you going to be doing neuro checks? Absolutely. But the big thing, keep it immobilized. Principles of managing soft tissue injury include what do you do for a sprain? And that's your rest, ice, compression, and elevate, right? Very good. An epiphyseal plate fracture in children may what? I like that x-ray picture. It really shows at the end of the bone what's going on there. It's like a fragment sitting there. Remember, we do open reduction, internal fixations, plates and screws, and try to get it as straight as we can because we want the bone growth to be the way it should be. We don't want a crooked arm or leg or finger, or we don't want it, one shorter and one longer. And that's what will happen if we don't fix it right. What findings for a patient in skeletal traction indicates peripheral neurovascular impairment? Can you imagine having a fractured femur? Look at those little sharp edges sticking out in those muscles. Can you imagine how much that hurts? So neurovascular impairment's all about pulses. There are no pulses. You start out, what's the capillary refill? And then you go on from there, right? A multi. How should the nurse care for the skeletal traction for a child with a fractured femur? So, skeletal traction, when you have traction on skeletal skin traction, what making sure is something's pulling something, making sure documenting the weight. The other thing is you never take that weight off ever, okay? And you never decrease it. You keep it the same and make sure it's free hanging so it's pulling the way it should. Never take it off. When caring for a 9-year-old in Buck's traction, what action by the nurse is correct? So is checking capillary refill. Absolutely. And making sure those weights are free hanging there. Very good. What position do you put the legs of an infant with hip dysplasia? You're putting them in a Pavlik harness. How do you put it? What do they do? And it's called abduction, okay? Remember, Pavlik harnesses, 23 hours a day, check underneath, rub the areas if you need to, and have like a cotton undershirt. Prevents that chafing. What statement by parents indicates more teaching regarding their 2-year-old infant with club feet? More teaching is needed. Which one here? We do it every week, okay? And then we're going to need follow up with, the podiatrist, the orthopedic guy, to make sure that their feet are still maintaining the same thing. Remember, they heal so quickly. You don't want to wait for a month. And you start treatment as soon as you can, because those first 28 days, they heal really quick. A multi. Osteogenesis imperfecta. What is it? I've actually seen a couple children with this, and you really do treat them differently. We used to use the baby blankets to lift them up and move them around because you didn't even want to touch them. No, there's cases that children with osteogenesis imperfecta, the parents have been arrested for child abuse until they figured it out. It wasn't their fault. It's a condition, so it can happen. Long bones are crooked, they're brittle bones, and you're not going to do physical therapy on these children. Aggressive physical therapy will make their bones crack and break. What is the pathologic cause of leg calf burst disease? Where's that fuzzy area on the head of the femur on that where it goes right into the hip joint? It's called an ischemic aseptic necrosis of the femoral head. That means blood is not going there, the supply is decreased, and there's no infection going on. Again, we rest, maybe put them in Buck's traction, NSAIDs for pain, and making sure we give them a good, healthy diet. Vitamin D's, calcium, protein, right? Kyphosis, which one is that? I think of kyphosis, I think of older people. I'm not that old yet. It's a humpback. A multi-select. What assessment indicates an infant has developmental dysplasia of the hip? What do you see? So moral fleet reflex is at birth, that's the startle reflex. Babinski is the foot that we see, but has nothing to do with dysplasia. You're going to see those leg folds. They're different. One leg is shorter, and they're a positive Ortolani sign. You can hear that clicking in those hips. Something's wrong. Lordosis is described as and that's that inward curvature of that lumbar spine. We do see that with Duchenne muscular dystrophy. Scoliosis is what? And that's the S-shaped curvature on it. Adolescents with scoliosis that have up to a 45% curvature of the spine would need to do what? What's the treatment? In that person, 45, usually, sometimes even to 50, but they say 40 to 45. It's all about doing physical therapy, putting on a brace 23 hours a day. And then after that, they would consider that surgery, the Harrington rods, the Lukey rods, or a spinal fusion that it can be called. But it's a brace. And again, put something underneath. And the other thing about adolescent scoliosis, remember body image, that brace, it makes them feel very self-conscious. Multi. Teaching for a child with scoliosis with less than a 45 degrees of curvature. And it's all the above. You're going to wear it 23 hours a day. You take it off to bathe. Underneath should be a cotton shirt, whether it's a t-shirt or whichever they're comfortable in. Never put lotion underneath there because it can get moist and create problems. And then physical therapy, so very important that they keep their muscle strength so they keep their spine from going back to that S-shaped curve. Multi. A Pavlik harness. A little bit of everything, right? So Pavlik harness is used for the developmental dysplasia of the hip. That means that socket, the femur head does not go right into the socket in the hip. It's somewhere up here. Also, it holds the hip in abduction so that it can force it to go back where it needs to be. Always check the skin underneath the brace. And when the brace comes off, look at those areas, might be a little reddened, and just, massage it so that we increase the blood flow, so we prevent any skin breakdown. What is osteomyelitis? So itis is an inflammation. Osteomyelitis is an inflammation due to an infection, and it is very serious. If we don't take it seriously, we don't treat it, it can cause systemic infection. Also, it's a loss of a finger, a toe, a limb. So very important. Goals for juvenile idiopathic arthritis includes what? So JIA is all about the body attacking the joints. And let me tell you, it does hurt and it does swell. So our goal is to reduce the pain, reduce the swelling. And in children is trying to keep them as active and as normal as other children without it. A multi. What might you anticipate for a child diagnosed with JIA? So joint disfigurement, difficulty walking, stiffness, especially when you're sitting for a long time or in the morning, and then uveitis. It's that gets reddened in there and cause blindness. Facial rash is lupus. What is cerebral palsy? Cerebral palsy, it affects body movement and muscle coordination. These children have this, especially if it's what we call spastic cerebral palsy. They're so tight they can't control what their body is doing. Multi. What are the signs and symptoms of spastic cerebral palsy? This is my little Jonathan for sure. Poor posture, poor fine motor skills, hypertonicity, poor balance. These are children who are in a wheelchair because they can't get up and move, that we need to make sure they're strapped in properly. They will go down. And fine motor, he can use his pad to talk to us, but it takes a time because of that spasticity that he has. And feeding, well, he doesn't take anything orally. He's nonverbal. He has a gastrostomy tube. But if not, we'd have to help, or he would try to get it to him, and he's so spastic he can't. multi. When feeding a child with cerebral palsy, what's important to remember? So let's say this kid is able to eat. And as I said, you might have to feed him because he can't get the spoon to his mouth without dropping it. So these children are at total risk for aspiration. That's the big thing. You would use thicker liquids. That helps prevent aspiration. And then, of course, they're not going to be able to chew and to swallow as quickly as normal children. Give them time. They don't only need gastrostomy tube feedings. Jonathan just couldn't eat. It doesn't mean that they're not trying with certain things, but mostly the balance of his food is gastrostomy tube feedings, but not always, not all children. A myelomeningocele, what's that? So myelomeningocele is the spinal cord and meninges are ripped up from the lower portion and up on the outside of the body in this big concealed sac. Okay, remember what that does. It rips the nerves to the lower extremities, the urinary bladder, watch, constipation, watch, and then movement is going to be decreased. A multi. What can help a child with lupus prevent its aspirations? What are some things that can cause flares? We know stress, we know hormones, absolutely. But what else? So one of the things is sunlight. I mean, I live in South Florida, so this is a big thing that I do need to teach. Also, these children are going to be getting prophylactic antibiotic steroids to prevent the body from fighting against itself. There is no need for increasing fats in the diet. That has nothing to do with lupus. A normal diet is fine. Infants with a myelomeningocele demonstrate what? Those nerves have been ripped up, the spinal cord and the meninges and the nerves been ripped up and out. They're going to have decreased motor and sensory impairments. Absolutely. They may not be able to move or minimally move. They may feel it, they may not. Myelomeningocele have decreased motor and sensations of lower extremity. The nurse should monitor closely what? It's all about urine and stools. Now, can they get skin breakdowns, contractures, foot drops? Yes, that will be like an everyday exercise type thing. But urinary retention and constipation are the ones that should be monitored very closely, okay? Because we don't want the bladder to get so big, it will burst if you let it go too far. And constipation, if it gets to be too long, again, peritonitis. A key feature of Duchenne muscular dystrophy is, and I love this picture, as everything that you might see. Duchenne muscular dystrophy, muscles and dystrophy. That means a progressive muscle wasting. We know that Duchenne in the end is the muscles of the diaphragm and the heart, which fail. So heart and lungs fail, and that's why they usually die. usually in the teenagers. It is one of the procedures that a child with possible Duchenne's may need to diagnose this condition. I mean, we need to find out, are the muscles working? Are they getting weak? And how would we do that? And it's called an EMG. And they either take a sticker, sometimes little needles, but usually just like those little stickers, like for you would do to monitor the heart. And they put a electrical impulse. They see how long it takes from the impulse till the contraction of the muscle and how strong was that contraction. Remember, after this procedure, it's like they've exercised for the first time in 2 years. They're going to hurt. So let them know that and, prepare them. They can have Tylenol Motrin when they're done to help them. It goes away. How is Duchenne muscular dystrophy inherited? It comes from mommy. I know many years ago there was a question on the HESI about a mother who found out that her son has Duchenne muscular dystrophy and should she have another child. And one of the things is to let her know that, well, you need to do some sort of testing, right? Looking at those things. Also, it is known to be an X-linked recessive pattern that she's the one who does carry it. And then she needs to make a decision. Does she want to have another child or not? It's not our decision, it is the parent's decision. In caring for a patient with Guillain-Barré, the priority concern is what? What's your priority here? Guillain-Barré, it comes from the feet and ascends up, and when it hits that phrenic nerve, the diaphragm doesn't move and these children don't breathe. Biggest priority is maintaining that airway. So it would be putting, if these children are in a hospital, they need to be in some sort of step down or ICU to be monitored, a minimum of an O2 saturation monitor to make sure we're monitoring it closely. For a patient suffering with Guillain-Barré, they would complain of weakness that was what? Remember, this is nerves, and the nerves stop working, and it causes weakness. No nerves, you'll be weak, and it's from the feet, and it goes up, ascending. And then all of a sudden, it starts working, and then you start breathing again, and it descends and it goes down. So those are the different terms there. A multi-select. What is the treatment for Guillain-Barré? They say Guillain-Barré is due to some sort of viral infection that you had, like a month before. And that viral infection, attacks the nerves in the body. So, since it's a viral infection, it's the intravenous immunoglobulins. Antibiotics are going to do nothing. Would we use heparin? It's not the treatment, but because they are not moving, they might use it for prevention of blood clots, right? But it's not treatment for Guillain-Barré. It's the immobilization it's used for. And of course, it's going to be respiratory support. They're going to be getting intubated. And if it's a prolonged intubation, they'll be getting a tracheostomy, right? If it's more than 2, 3 weeks, they'll say, well, you got to take care of that trachea. They'll put in a tracheostomy. What types of cerebral palsy causes hypertonicity and poor fine motor skills? I love this picture. Mom's letting them pull out money out of the ATM. I think that's really good. But hypertonicity is spastic. That's the one that they have no control on their muscles and, poor posture, poor muscle control. And they can't do things like you saw mom holding that child's hand to push the buttons on the ATM. They don't have control. What priority action should a nurse take to a patient with a suspected spinal cord injury? And this is priority action. Priority is keeping that spinal cord straight. When I took that child into that MRI, and I had like 6 different people in there with me to help, I was in control and they could not touch that kid, do anything. It was all on my count. And I took that neck. It was mine and I protected it. And because of that, this kid is up and walking and normal today. You should get a tetanus shot every how many years? And it's every 10 years. As I said, it's changed over the years. They're doing tetanus with diphtheria now. They're doing double shots. They're feeling they need also to boost that one if you weren't aware about that. What is a symptom of tetanus? I stepped on a rusty nail and it's lockjaw. Remember, it's all upper airway swelling causes bronchospasm, respiratory distress. And these children are sick. Many of them don't make it, but they say after 4 days, they come back, they'll be okay. Longer than that, chances go down drastically. Most common causes of a spinal cord injury are what? Spinal cord injuries, motor vehicle, driving, sports, anything that's, motion that can happen with it. Very good. Number 3, Turbo. You're 3 today. Number 2, Morgan. Good job, Morgan. Number 1, BB. That's Betty Bogart, right? And YGT and Akela. So we still got a couple of minutes left. I'm going to ask you what you all would like to do. I have 2 proposals for you. We can do 2 things. I can go over last week's quiz to give you those, concepts, or we can do a little bit of math. We've got about 10 minutes. What would you like to do?
Last week's quiz.
Is everybody okay with that? Did I put you all to sleep today? Yeah? All right, let me pull it up. Let me get it. And I think that would be a good idea because there's a lot of concepts on this that, we're having an exam next week. Possibility is strong. I mean, grades went from low to perfect. So, all right. Now I can't show you the quiz, but I can give you the concept of what these questions look like, okay? So, all right, you have a child. They fell out of a tree. So they've got a concussion. So with a concussion, what are you going to teach a parent? What are they going to see with this child? Anybody?
Child's gonna be
Vomiting.
tired.
Well, we know increased vomiting, increased headaches we're worried about. But remember that level of consciousness, they could have a little bit of behavioral changes. And that actually was the answer on this one. It didn't go into vomiting, it didn't go into headaches. So it's not a few episodes, it would be an increase and you'd be concerned about. A couple is normal, okay? Hypothyroidism and children, what do you know? Well, we know that adults and children are the same symptoms. And the only difference with it, what do you see different when you don't have enough thyroid hormone? What's the difference do you see in children? We have dry skin, constipation, cold intolerance. But in children, if you don't have enough, it's related to growth and cognition, right? Remember at birth, what do you see with a child with hypothyroidism, an infant? If they have no stool, one of the tests we'll run is the thyroid hormones, right? So those are some things to think about with hypothyroidism and children. The differences, the growth and cognition. And one of the things that leads us to check for it is constipation or no stool in the first day or two of life. Hypoglycemia, what do you see?
Shaky, diaphoresis.
Absolutely. Shaky, dizzy, diaphoresis. How do you treat a child that's alert, that has these symptoms, and yet they're a known diabetic? How would you?
Orange juice.
You could give a sugar cube or there's sugar pills. You could give milk, orange juice. Always remember, though, that burns up pretty quick. They need some sort of protein. I always say to have a turkey sandwich on standby, right? Good protein. Now, you've heard several times that I was one of the trauma nurses. I'm a trauma junkie. I love being in charge and I love taking care of my children because I could keep everybody organized and calm. I did not make extra stress in the room. I kept everybody calm. When you're looking at a Glasgow coma scale, what are you measuring? There's three things. There's three things. The lowest score you can get is 3. Eye-opening, verbal. Are they talking? And motor responses. When you get a child who rescue says Glasgow coma scale of 15, that is perfectly normal. But if that kid, they're telling you it's 6, this is the child you're going to have extra resources come in before they get there because that kid's going to be sick. Okay, what do you see with a child that has a brain tumor and you don't know it? What would you see? Common clinical manifestation. What do you see?
A headache.
Headaches that get worse and could wake them up at night. And the vomiting not related to eating. Those two things. Diabetes insipidus, what do you see? What are the two things?
Excessive thirst.
Yes, polydipsia,
Polyuria.
polyuria. What do you see in diabetes mellitus symptoms?
The same in polydipsia.
And polyphagia, hungry.
Phasia.
Hey, it's okay. Polyuria, polydipsia, polyphagia. So it's 3 for diabetes mellitus, 2 for diabetes insipidus. Remember, when I look at it, I just sort of pi is 2. That's the way I remember it, but I'm weird that way. A child has increased intracranial pressure due to cerebral edema. How do you treat it? What drug works?
Mannitol.
Why not furosemide?
Isn't mannitol like neurospecific?
Yes, it is. Absolutely great, great answer. Yes. Mannitol is used for the brain. It's used sometimes with toxic ingestions and sometimes with kidney failure. But mannitol is specific to the brain. And this is the white, thick stuff in it, and it's immediate. How do you know that it works? Well, you're going to see a massive increase in urinary output. Growth hormone in children, how is it delivered?
Subcutaneous.
It's just like giving insulin. It's a really something that parents and child need to know, that they're going to be getting an injection every day, because it's a big, big commitment with it. How do we know it's working? They're growing. And when do we stop giving it? It's when they stop growing less than 1 inch per year, and then we stop it, usually right at that pre-adolescent growth time. Hypoparathyroidism, what does that do? What's a parathyroid regulate? Parathyroid.
Is that the calcium?
Yes, the parathyroid regulates calcium, okay? Hypoparathyroid, you don't have enough. Remember, calcium and magnesium all have to do with muscle contraction. You know, calcium channel blockers, right? It relaxes it in order for the blood pressures to come down. It's a blood pressure medication. Too much is a spasm, and too little, it's floppy and not working. So calcium regulation. And then whenever you have a group, and this was one of those, you've got 4 children, which one do you check first? Whenever you're talking about head injuries and you're talking about who do you need to check first, it's that child that you know by their signs and symptoms they're getting worse. What head injury that's getting worse, what would they show you?
Decrease LOC.
There you go. Decrease in the level of consciousness. Yes, it is, and that's the answer. So that was your exam, your quiz for last week. Anybody have any questions? Because we're good for today now. Remember, you have your discussion question. You do have your calculate with confidence. This week is a bunch of reviews, so I will be posting them. And next week, come a little early so that we can set you up for your exam. I wish you good luck, guys. Anybody who wants a 1-to-1, a 2-to-1, a 6-to-1, let me know, okay?